So I will be giving a lecture today about instead. I'm still Ahmed Shatila. I'm still a neurology consultant at SSMC, and I'll be talking to you today. Let me share. You see my screen?
Yes, we can see your screen.
Excellent. Okay. There we go.
Yep, it's full screen. You can
Thank you, Gerard. I will be talking today about interferon betas and Mavenclad or cladribine. This lecture is sponsored by Merck Pharmaceuticals. Thank you. Here are my disclosures. So when we have someone with MS, there are multiple things that you have to keep in mind before treatments are even started. You want to look at the benefit-risk profile. You got to look at the dosing frequency, monitoring requirements, the burden of monitoring. You want to check the device, whether they prefer injectables, orals, or infusion. But last but not least, you need to think about pregnancy. And why pregnancy? Because MS is predominantly a young female's disease. It affects women twice as many times as men. It affects young women. Average age of onset is 30. And in one study, pregnancy is a key consideration for women of childbearing age in MS. MS has not been shown to have an impact on the ability to conceive or the ability to carry a child to full term. Studies have shown that MS has no significant impact on the ability to conceive for women, nor no impact on the ability to carry the baby to full term, and there's no increased risk of spontaneous abortions. In regards to the infant, there's no risk of premature birth, no risk of stillbirth, and there are no fetal developments or birth defects. How does pregnancy affect MS? In this famous study published in the New England Journal of Medicine by Confavreau, what it showed was that during pregnancy, actually the disease gets better. Relapse rates go down, energy goes up, and it stays like that throughout the course of the entire pregnancy, with the increase usually 3 months after delivery, as you can see right here. In regards to medications for MS, there are a lot of medications. We have over 15 medications for MS, and all of them need some sort of pregnancy planning or at least discussion on pregnancies, and with exception to the interferons, and I will get to that next. In regards to unmet need in pregnancies, like I said, when you have a patient in clinic, you have to before you even start medications, you want to know, first of all, does she want to have kids? Is her family complete, or would they like to have more children? Because your treatment decisions will change. I mean, for example, if someone tells you, if you have a patient and she says, I'm looking to have children, and she says in the next 3 months, your treatment option and your choice of medication will change significantly versus someone that says, I'm interested in having children in the next 2 or 3 years. During pregnancy, you also have to think about the medications you're using. Some medications can have rebound activities if you stop it, such as fingolimod and natalizumab, Tysabri. And then postpartum, you need to consider whether the patient wants to breastfeed or not, because again, certain medications will pass through the breast milk, and that can limit their ability to breastfeed. So with that, I'm going to tell you today that interferon beta 1A, Rebit, is now approved to be used during pregnancy and breastfeeding. This label has been updated both by the FDA and the EMA, as well as the local chapters or local health departments in the UAE. It is safe to use during pregnancy. It's also safe to be used during breastfeeding. Now, how was that decision made? It was made because this medication, interferon beta 1A, has been around for more than 20 years. We have more than 1.7 million patient years. I was always told, once you go over 1 million patient years, there's no more surprises. You know everything there is to know about a medication. There's no risk of serious infections, no risk of malignancies. And PML, the bane of every neurologist's existence who takes care of MS patients. Prior to 2005, prior to natalizumab being approved, PML was strictly a disease for the HIV patients, patients on strict immunosuppressive therapies. And after 2005, for the first time, we started seeing PML in patients with MS who were being treated with natalizumab. And because of that, every new medication that ever gets approved, that's the first question everyone asks. What's the risk of PML? There are no risks of PML with interferons. In regards to breastfeeding and breast milk, interferons do not readily transfer into breast milk because it is a large molecule. It is tightly bound to T cells, so there is no passage to the milk. And even if it does pass, the amount of interferons that go into the breast milk are only 0.0006% of the maternal dose, an extremely small number. And even if that small number does pass and does get ingested by the child, due to poor oral absorption of interferons, it is not expected to be absorbed in the bloodstream of breastfed infants. Because of that, it was approved for breastfeeding. And how was that decision made? There's been over 16,000 pregnancy outcomes assessing the safety of interferons during breastfeeding and pregnancy. The proportion of live birth with congenital abnormalities in patients exposed to interferon betas were consistent with the general population. There was no increased risk of spontaneous abortions in people who were taking interferons versus people in the general population. The mean birth weight and birth length of infants born to patients exposed to interferon beta 1b were consistent with those born with patients exposed to unexposed to DMDs. Overall, there are no evidence that interferon betas exposure during pregnancy results in adverse pregnancy outcomes. And this was based, as I said, over 1,600 pregnancy outcomes. Because of that, you can now give interferons throughout the entire stage of disease. And this is something I sometimes do. If I have a patient who doesn't know when they want to get pregnant, who has mild disease, who may be interested in breastfeeding, I will choose interferons because it is a safe drug. It does work. It has been shown efficacy. It's safe it does work effectively for patients with MS. It is safe for pregnancy, safe for breastfeeding. There's no risk of rebound, and there are no side effects that we do not know about. The major side effects of interferons are flu-like injection reactions after taking the injection. Now, if PML is the bane of every neurologist is existent, and COVID has now caused a headache for everybody else. And in a recent published article in the Lancet of Neurology 2 months ago, where they looked at the effect of interferons, actually the effect of all the DMDs, there was no increased risk of interferons causing an adverse outcome in patients who were infected with COVID. It actually appeared to be protective. And this could be a result due to the fact that interferons do have an antiviral effect. Way before it was approved for MS, interferons were used to treat hepatitis. So there is probably an antiviral effect, and that's why interferons appear to be safe and actually beneficial for people who were exposed to COVID. All the other DMDs did not show this. Now I'm going to talk to you today about Mavenclad as well, cladribine tablets. Cladribine is a drug that's been approved around 3 years ago in the UAE, and it was based on a study called the Clarity and the Clarity Extension, where patients were given 2 years of medication. This medication is given on body weight, meaning that you have to calculate the patient's body weight, 3.5 milligrams per kilogram for the total dose over 2 years. Then that 3.5 mg per kg is divided. Half of it's given in the first year, the other half is given in the second year. And then in the first year, you divide that dose into 2 months. Half that dose is given in the first week of the first month, the other half is given in the first week of the second month. Then they're not on any medication until the second year, where you restart the dose all over again. In this Clarity trial, there was a 50% relative risk reduction compared to placebo and annualized relapse rates. There was a 47% reduction in confirmed EDSS progression, and there was an 86% reduction in new gadolinium-enhancing lesion on MRI, and overall there was a reduction of 73% on new T2 lesions. So, as I said, in the Clarity trial, the patients got medications in the first 2 years, In year 3 and year 4, they did not get any medicine and they were observed. How did the patients do in year 3 and year 4? So 77.8% of patients who received the medication were relapse-free in year 1 and year 2, and 75.6% of patients, although they did not receive medication, they were also relapse-free in year 3 and year 4. So while you're only getting medicine for the first 2 years, this medication or this drug appears to work for 4 years. And when you look at NIDA, same thing. So in the trial, patients were actually also, and I didn't mention this, but in the trial, there were a group of patients that got cladribine, placebo. So they got cladribine for the first 2 years, and then they got placebo for the next 2 years. And there was another group that got cladribine every year for 4 years throughout the study. And as you can see through these two bar graphs, there was no difference in disease activity in the patients who received cladribine for 2 years versus the patients who received cladribine for the entire 4 years. In regards to lymphocytes, cladribine works on adenine deaminase, which is an enzyme used for pyrimidine synthesis in white blood cells. And the most common disease that you see when you have ADA deficiency is the SCIDs, subacute combined immunodeficiency syndromes, or as it's classically known as the children that used to live in plastic bubbles back in the 70s and 60s. This drug affects that enzyme. So what you're going to see is you're going to get a slow decrease of lymphocytes after you take the medication. It slowly goes back up. Usually the drop in lymphocytes are not severe, usually well within the low normal range. Year 2, you give the second dose, you get another drop. Again, usually not less than 800 in my experience. And then it slowly goes back up within normal. But then year 3 and year 4, you are now above normal, but the medication still has an effect. So what exactly is happening when you're giving medication for 2 years, but you're getting an effect for 4 years? And this goes under the idea of what we call immune reconstitution therapy. Now, immune reconstitution therapy or induction therapy is a new idea in the treatment of multiple sclerosis. And what that means, most of the medications for MS are what we call maintenance, meaning if you take the medicine, it works. You don't take the medicine, the disease comes back. 2 medications have been classified under immune reconstitution therapies. The first one is cladribine, the second one is alemtuzumab. And what this does is, you can take the medicine, as you can see on the little illustration on the left, you've got your regular lymphocytes with the little bad orange cells that are causing your MS disease, MS relapses. You take the medicine, you get a drop in all your B and T lymphocytes. But when they come back, usually a year later, your immune system, it comes back different. Why does it come back different? We don't really know. But the disease is not the same after the medication as it is before the medication. And this term is called immune reconstitution therapy. What's the safety of it? Cladribine has been studied consistently since 2005. Even though it got approved at around 2016, 2017, we have now information for more than 13 years through different studies, the Clarity extension. There's the Onward trial, which was the phase 2B trial looking for active relapsing remitting patients, how they did. You had the Oracle, which was used for patients with CIS. So we have more than 12,000 patient years of experience on this medication. What were the side effects? Other than decrease in lymphocytes, which is the mechanism of action of the medication, there was no increase in no other serious side effects, no other things other than herpes zosters, which is usually associated when the lymphocytes dropped below 200. In those patients, you needed to give oral acyclovir. It's not very common, but it's actually pretty rare. It's only 0.7%, which is 7 cases in every 1,000 patients. So with that, when you look at people with MS, and just to compare the overall dosing burden of cladribine versus a patient, this is the dose of Tecfidera, dimethyl fumarate, over 4 years. This is the dose of fingolimod over 4 years. And that's the dose of cladribine over 4 years. pretty impressive. As I told you, the rate of herpes zosters was 0.8. I said 0.7, my apologies. 0.83, that is 8.3 cases for every 1,000 patients. It usually increased for people who had a lymphocyte level less than 200. And in those patients, you need to give them oral acyclovir. In regards to other infections, there did not appear to be any increase of other viral infections in patients who were receiving cladribine versus placebo. Vaccinations. Because this is an immune reconstitution therapy, your immune system, as I told you, when you take it, your immune system, you get a drop in your lymphocytes, but the medication is out of your body within 7 days. But yet the effect is actually lasting for 4 years. So once your lymphocytes return to normal, you are no longer considered immunosuppressed. So you have a normal immune system. You can take live vaccines, you can take attenuated vaccines, you can take dead vaccines. The reason why you can is because you have a normal immune system. And this is something extremely important, especially now in the day of COVID, when we're talking about new vaccinations. For all we know, this is going to be something our patients are going to be talking to us in the next couple months. The only 2 medications that you can take live vaccinations are interferons, they're safe, Mavenclad after your lymphocytes have gone back to normal, and alemtuzumab once you're 4 months after the first dose. Those are only medications. For everything else, you cannot take live vaccines. You can only take dead vaccines.
3 minutes, Dr.
Thank
Shatila.
you. Pregnancy planning. This drug, because of pregnancy, it is out of the system in 7 days. So 7 days after your last dose, you can breastfeed. I have a patient right now who was on cladribine. She had a child that's 7 months old before she took her dose of cladribine. I told her, wait 7 days after your first dose, breastfeed, and then the second month, 7 days after the second month of cladribine, and now she's breastfeeding. So she will start breastfeeding in another 3 days. And during this time, she's doing pump and dump, so in order to keep her breast milk going. With this, I would like to end the webinar. I would like to show us a short video, just kind of highlighting who has MS. This was from Merck. I really like this video, and we'll go from there. Okay. Oh, sorry. Stop that. How do I end the sharing? Hello?
Hello, Doctor. Just bear with me 1 minute. It's fine.
Okay, how do I stop this sharing?
There we go. Okay, you come back to the webinar.
I'm back?
Yes.
Excellent. I'd just like to say, with the end of this, over the course of the last 3 days, you have heard multiple lectures on multiple sclerosis, different drugs. And the purpose of these webinars are not to prescribe. I do not expect my primary care colleagues to prescribe any medication, but what we know, these are our friends, our families, our coworkers, our significant others that may have options, that may have MS. And in 2020, there is no reason why anybody with MS should not be treated. And because of this, there are options. And the discussion for treatment doesn't start with me. It actually starts with everybody in primary care. And this is the purpose of all these webinars, to raise awareness so that we can treat everyone. Thank you very much. And with that, have a nice day. Thank you.